Well, I did my surgical residency at Boston University, Boston City Hospital. There were no colon and rectal surgeons on the faculty there. My dearest friend, whom I had started out as an intern with, continued on through. I did 2 years in the lab. So he was a chief resident, I was a third-year resident. And he had been accepted at the colon and rectal training program at the Leahy Clinic. My plan was to do gastrointestinal surgery, particularly biliary tract, which is what I had done my research in. And so David went to the Leahy Clinic to do the colon rectal residency with Weidenheimer, Corman, and Collar, and said to me, "You really have to come and check this out. It's a specialty that he thought that I would really like." So I spent a day with him and Dr. Weidenheimer in the office and in the operating room at the Leahy Clinic, and on the basis of that decided that that's what I wanted to do with the rest of my career. It really was first of all, how much they seemed to enjoy what they did. They had horrific office days, they had very busy operating days, and yet they were always seemingly happy with the clinical work that they did. I liked the easy interaction that they had. There was a lot of teaching by example. And so it just seemed that they were comfortable in doing what they did. And that was, more than anything else, what influenced me to start thinking about colon and rectal surgery.
Now, that year at Leahy, you worked with the three people you named, Weidenheimer, Corman, and Collar, three totally different people. I mean, absolutely different personalities and stuff like that. How did that sit with you? How did you reconcile working with three people who were so totally different?
Well, actually, Marvin was so worried about my coming, he left and went to Santa Barbara. So actually, I had 6 months with Weidenheimer and 6 months with Collar,
Okay.
which was an interesting experience in having 3 months each with each of them on an alternating basis. Both extremely interesting individuals, both very different one from the other. But overall, it was an outstanding preceptorship kind of arrangement. John Collar was the person who had brought colonoscopy to the clinic. Mike never did colonoscopy, so we learned our colonoscopy from John in basically an immersion type of experience.
Dithering.
A lot of dithering, a lot of torquing, a lot of where's John, I'm still stuck in the rectum kind of thing. But at the end of the day, it made you into an independent, reasonably skilled colonoscopist. Mike was an extraordinary technical surgeon, gifted technical surgeon. I really could have spent my entire professional career first assisting him. It was such a joy to work with him technically. I only learned afterwards that traditionally he did not let the colorectal residents do much surgery. And yet, because he was potentially interested in hiring me, he had to let me do some operating. So I would hear from the nurses in the operating room that it was so unusual for him to actually be letting the colon rectal residents do any surgery this early in the residency. Well, it was because he was trying to see whether he would hire me to fill Marvin's vacant position. But it, I think, convinced him that he could actually let the colon rectal residents operate, and so he basically continued that for the rest of his career at the clinic. He let the residents do a lot more surgery.
And when in that year were you offered the job?
Well, I had an offer to go back to Boston University and join my general surgery mentor, a fellow named Lester Williams, who was the chief of surgery at BU, and it was in Lester's lab that I did the 2 years of biliary tract. And then when I decided to do colon rectal surgery, he kind of shifted gears, and the plan was for me to finish the year of training at the clinic and then go back and join him and another guy who's from England and form a 3-person GI surgical unit with one colorectal surgeon, and Dr. Williams did mostly pancreas and biliary tract. So that discussion was taking place, and I think that Mike was trying to cover a lot of patients with Marvin having left. And so he was, I think, acutely feeling the need to add somebody to the staff, and I just happened to be there. So it was probably in November that discussion started with regard to my taking that job at the Lake.
How many residents were being trained at the time at Leahy?
Well, we didn't have any general surgical residents. We had 5 people, 2 colon rectal residents, 1 vascular in a non-approved vascular fellowship, an American Cancer Society fellow, and then a 4th-year resident from the Brigham.
And who was your counterpart in colorectal surgery?
A fellow named Bob Oringer. Bob subsequently went to New Jersey in private practice, joined a guy who had trained at the Leahy Clinic named Dave Lawrence.
And now you have a choice between doing something maybe in private practice or staying in a academic institution, because the clinic was known to put out a lot of papers, do a lot of clinical research, etc. Where was it that you had some inkling about academic surgery?
Well, having done 2 years of research during my general surgery residency, I thought that I was going to pursue a predominantly academic career. I think I had some idea what an academic career might entail. My observation of the Leahy Clinic was that it was what I've often referred to as para-academic, where you could have all of the good things of an academic career, and yet you didn't have to go through the competitive granting procedures that a lot of academic department members have to go through. So I thought that it would be fairly straightforward to do a clinically academic practice at the Leahy Clinic. Now, my research in biliary tract had been in motility. So when I finally agreed to stay on at the clinic, I was going to build a motility lab. But Dr. Collar, who's far smarter than I, came up with his continuous water perfused manometry system, and he developed a manometry lab rather than I, which worked out okay because I was pretty busy clinically.
So now you're at Leahy as a faculty member. You're the 3rd arm of this triangle, and now you're going to teach residents. You're brought up in a system that you let the residents do the cases. You're first assisted in most cases, unless somebody had this false idea that if you operated, they would do better.
Well, Mike told me that if I were to take a job at the clinic, that for the first 3 years of my practice, I could not let a trainee do a case. And I told him that that was a deal breaker in terms of my taking a job at the clinic, that it was my belief that as surgical educators, we needed to teach people how to operate and confirm that they had the basic skills and then improve their skills as a result of working with us. That it didn't do as much good for them to watch me do anything as it did for me to help them to get better. So he actually relented on that. It took a lot of discussion to get him to give up on that. That apparently had been
November to June.
Yeah, that had apparently been the way it always had been at the Leahy Clinic, was that for the first 3 to 5 years of your practice, you couldn't allow a trainee to do a case. They could first assist you. Now, what I did want to do was to ultimately take over the training program in colorectal surgery, because I thought that there were lots of improvements that could be made on the overall quality of the training. So Mike acquiesced and let me take residents through cases, and fairly quickly after I started made me the associate program director, and then allowed me to be the program director for the residency at the clinic.
How long were you there before you became program director?
It was about 3.5 years.
3.5 years. Now, that took another load off Mike's shoulder. You helped him, reduce his clinical load, and now you helped him reduce some of his responsibility as far as ACGME. He was still the department head. And so he dealt with the Leahy administration for budget, and you had to deal with ACGME for residency. And at what time did the resident numbers increased?
Well, we stayed at 2 colorectal residents. I think actually the residency program had its first resident in 1964, and stayed at 2 colorectal residents until it was somewhere in the late 80s, early 90s, we went to 3. But then the institution decided that they wanted to have a general surgery residency. So we agreed to do away with one of those colorectal residency positions in order to support the general surgical residency. So we went back to 2, where we are now. We have 7 staff now with 2 colorectal residents.
So tell me about when did you start to recruit additional staff? Was that associated with Mike cutting back some of his clinical work, or
no? I
just
think
the clinical work had increased sufficiently?
The clinical work really was increasing. The clinic moved from downtown Boston to Burlington in 1981. So I was actually in the first residency year that spent its entire year in Burlington. So when they moved from downtown to Burlington, it wasn't clear as to how the practice would develop. They knew that they were going to lose some downtown business, but they assumed that by being out in the suburban areas on a highway, that would open up the clinic to people from all over New England. There was a gamble in that, but it turned out that they were correct in that assessment. So the practice was growing remarkably. So the increase in staff was predicated on the need to have more surgeons to do the work that was already there.
And who was the first and second person that you recruited?
First person that we recruited was John Murray. Second person that we recruited was Pat Roberts. And then Peter Marcello. And then Tom Reed. And subsequently we've got 3 more people, with one just having started a month ago.
Tell me where you got interested in organized medicine, because that has nothing to do with what's happening at Leahy. Let's talk about ASCRS, the board, the American College of Surgeons, external things.
The first of those organizations that I was exposed to was the ASCRS. And I remember getting a letter from the Audiovisual Committee, and under the leadership of Bart Hexter. And being a young hotshot, I said, Audiovisual Committee? I mean, I'm certainly more worthy of something more than the Audiovisual Committee. So I took the letter to Mike, stormed into his office. And I said, what is this Audiovisual Committee? And he said, I want you to write a letter back to the society, thanking them for the opportunity to be a member of the Audiovisual Committee. And if Bart wants 5 slides for the quiz, send him 10. And if he wants 10 questions, write 20. Whatever they ask you to do it willingly and do more than they ask you to do. A spectacular lesson. It was 3 years, and that was the committee that I was a member of, was the Audiovisual Committee. And I did just as Mike said, tried to do more than what was asked for. And that sort of behavior generally is recognized and rewarded. So got more significant committee appointments. And what I always tell our graduating residents is contact the society, tell them that you want to be a member of a working committee. And when they put you on a working committee, do the work, and do the work well. And I think there's still, even though the society has obviously grown quite a bit, I think that there's still a lot of opportunity for people to get in as a worker and to work their way up through the ranks of the society. As far as the board is concerned, Mike was extraordinary in terms of my career development. Mike was the president of the Board of Colon and Rectal Surgery twice, actually. He was one of the early representatives to the American Board of Surgery from our board. And I think that he used that opportunity for me to be able to become a member of the board. So I was a member of the board at a fairly young age. Was put on the exam committee. And you remember the exam committee meetings.
Very well.
So we would sit in hotel rooms and look at questions and rewrite them, and if we were lucky, we'd get dinner, and that would be the end of the weekend. So again, it was an opportunity to contribute at a significant level, and it was trying to make the best of an opportunity that I got because of a mentor. And that's another issue, is the mentorship issue.
That opened the door for other things, external things. Were you ever the representative to the American Board of Surgery?
No, I wasn't the representative to the American Board of Surgery. It just didn't work out from the point of view of timing based on my Board of Colon and Rectal Surgery term, since you need to be a 6-year representative to the Board of Surgery. So it's only a subset of people who are on the Board of Colon and Rectal Surgery who will be eligible for a 6-year term with the American Board of Surgery. It's a lot of commitment. Might have been nice to do it, but.
And the American College of Surgeons? Advisory committee?
Have been on the advisory committee, been the program committee chair for the specialty, been a governor. So yes, there's been participation in leadership positions at the college, been on the residency review committee, both as a member of the residency review committee and then chair, and now, as you know, as the executive director of the board, you're an ad hoc member of the residency review committee as well.
So you have worked for 4 different things, and which one of these have been more gratifying and more satisfying? And which one of these do you think is more important? Most important. It's
well, they've all been gratifying, but as you know, the board, I think, is, for me, far and away the most gratifying organization to have been involved with. The board, I still believe, is the reason that we exist as a recognized subspecialty. I am proud of the fact that we continue to be respected as the certifying body for colon and rectal surgeons. I think that we are respected among the 24 boards of the American Board of Medical Specialties. So I think that a lot of the work that you and your predecessors did and the current membership continues to provide strength in the specialty. And that's why I think the board has been the greatest labor of love.
You mentioned a couple of times the importance of a mentor. And what have you learned to pass down to the next generation as being their mentor either in areas related to academic medicine and organized medicine, or just the kids that come into the residency and they need direction?
Well, the residents at the clinic know my bias about the word mentor. Personally, I think it's been so overused that it's nearly trite. That many of the people are referred to as mentor by residents and others are really just advisors. They may be friends. Mentor, as I'm sure you know, is from the Odyssey, and Mentor was entrusted by Odysseus with his son. So there's a parental aspect to this. There's a religious aspect to this. There's a mythologic aspect to this. And I always tell the residents that they would be lucky to have one true mentor. I had two. So I don't like to refer to myself as mentor to many people. I like to be friend and advisor to all.
There's a difference between being a friend and being a mentor.
Yes.
Who have you considered to be one of your mentees, and you really made an influence on them?
Well, having heard her on more than one occasion refer to me as her mentor, Pat Roberts. I've known Pat since she was a third-year medical student and have had the opportunity to interact with her for years. That's been, I believe, a true mentoring relationship. Peter Marcello, to a lesser extent, Peter Marcello's father wrote my letter of recommendation to get my residency at the Leahy Clinic, so I've known Peter since he was in 9th grade. So I think those have been long-term relationships in which not only have I helped them with their career development, but putting their career into context of their life, and I think that's what mentors do. Is to help with bigger issues, or perhaps to stay out of bigger issues. And that requires more than just friendship.
In the last few minutes, if there's anything you want to talk about.
I think it's just important, and I think it's getting harder to keep this in some sort of a perspective. I think the external forces that are affecting the practice of medicine now are going to take their toll, because I think it is more difficult to transition into the new way that medicine will be practiced. So what I tell the students, and we do have students, is to make sure that you enjoy it, make sure that it provides you with great personal satisfaction to do it, and put it into some sort of perspective as to where it fits in your life, because it's different now than it was before.
And as far as the specialty is concerned?
Well, I think that the specialty itself is in very good position. I think that it will evolve into a 2-year type of training paradigm, I believe. Whether that will be associated with a reduction in the general surgery from 5 to 4, I don't know. A lot of that is dependent upon the Board of Surgery and what they will be willing to do. I think that, unfortunately, the financial aspects of the practice of medicine will make competitive forces even greater. And so everybody will want to take somebody else's business because it will be associated with money. So I think we have to keep our eye on what the prize is, which is to provide highest quality care in colon and rectal surgery for the public that we serve. And if we can do that, then I think we'll be fine.